everyone. Thank you for coming to the ABI Zoom seminar. Today we have Dr. Joseph Donnelly from Auckland Hospital. He's also an honorary senior lecturer at the Department of Anesthesiology. Joe did his medical degree at Otago and then received a prestigious Woolf Fisher Scholarship to study for his PhD in brain physics at Cambridge University in 2014. Yeah. So and he's already the fourth ranked medical expert in the field of intracranial pressure and published more than 120 articles on this field. So we have the right person to learn about this very important topic, especially for the traumatic brain injury. So Joe, you have our attention. Thank you for coming.
Thank you very much, Vicky. Thanks for inviting me to talk to the Bioengineering Institute. I'm really excited to talk today to ABI group. Normally, I'm giving these sorts of talks to simple clinicians like myself who can't tell their fast Fourier transforms from their wavelet transforms, but that's sort of by the by. I'm really actually excited about talking to you guys because I think critical illness and the physiological signals that we receive from our patient monitors represents an area in clinical research where bioengineers can have a huge impact. I think at the moment we have, at least in Auckland City Hospital, we have terabytes of data, waveform, high resolution data that just gets chucked in the rubbish bin, and we're not learning anything from that data, and therefore we're not doing our best to improve patient care. So I hope that I can pique some interest from you guys here as the experts in signal processing techniques, and you can tell me where I've gone wrong and hopefully provide some advice for me in my future studies. So a little bit about me. I started my research in the field of high altitude medicine, physiology, and moved into more critical care physiology and really trying to understand how we can use the signals that we get from the patient monitors at the bedside, how we can use that to decide who's going to do well or who's going to do bad in critical illness, but more importantly, try and work out how we can improve that physiology and improve outcomes. Most of my work has been in traumatic brain injury. So today I'll focus more on that, but I think in general this research area is applicable to all critical illness, all diseases where we have embedded monitors, ECGs, blood pressure monitors, intracranial pressure monitors. All right, so why study traumatic brain injury? There are lots of potential reasons, but the one that interested me was this graph here. This is looking at collated studies over the last 140-ish years and just looking at the mortality and severe traumatic brain injury. And let's accept that there are lots of caveats to a study like this and the reporting of cases and how do you determine what's a severe case and whatnot. But if we look back by the turn of the century, it was 60–70% mortality. We've seen quite significant improvements, but from 1990 onwards, so the last 30 years, we are still sitting at 30% mortality. So does that mean that we've just reached the ceiling? We can't get any better than 30% of our patients dying? Well, I hope not. I hope that perhaps we just haven't been looking deeply enough into these patients, and my hope is that by understanding the brain physiology, we might be able to improve this mortality and hopefully morbidity as well. So what causes the morbidity and mortality after traumatic brain injury? Well, after the brain is injured in those seconds after the assault or the car crash or the fall, the brain becomes very vulnerable to any further insults. And these insults can be caused by a variety of things, be related to metabolism, brain temperature, but the one that seems to cause the most problems is due to cerebral blood flow dysregulation. And that can be either too little cerebral blood flow, which causes hypoperfusion and fairly quickly ischemia and death of neurons, but also hyperemia, that's increased blood flow, is also not good because, as we know, the brain is within the rigid skull, and if we have too much blood flow in there, then we can have raised intracranial pressure, which has problems of its own. So really, after traumatic brain injury, we're in a very cautious state. We're trying to wrap that brain up in cotton wool so it doesn't get any further injury. So let's look at cerebral blood flow regulation in a little bit more detail. What's the physiology? We can break down cerebral blood flow into a simple light diagram, and we can easily understand that the blood flow will be proportional to pressures. And more specifically, it will be related to the pressure at the inlet. So that's the cerebral arteries, the middle cerebral artery. But it'll also be related to the downstream pressure in the venous system. The brain is unique in a way because it's surrounded by this rigid skull, and we have to factor in intracranial pressure and what effect that can have on the venular pressure. Because we know that when intracranial pressure increases, which unfortunately does happen almost universally after trauma, then these fragile veins that come from the surface of the brain and join this large sagittal sinus, the bridging veins, are very compressible, and they get squished if the pressure in the CSF space gets too high. So therefore, we can understand that the pressure just proximal to that compression will be roughly equal to intracranial pressure, maybe a tiny bit higher. This is useful for us because you can imagine that measuring a cerebral venular pressure is probably quite difficult, but measuring the intracranial pressure doesn't present such logistical difficulties. So we can effectively measure the inflow pressure, the mean arterial pressure, and also the outflow pressure, which we can approximate with the ICP, intracranial pressure. It also helps to think about the physiology of these pressures. For arterial blood pressure, we know it be related to the cardiac output, and anything that affects the cardiac output will also affect arterial blood pressure and therefore potentially cerebral blood flow. But it's also affected by the peripheral vessels, that's the total peripheral resistance. And this is important because one of the measures that we use in acute brain injuries to try and augment brain blood flow is to use vasopressors, which we hope work specifically or relatively specifically in the peripheral vessels so we can pump up that blood pressure and supply adequate blood flow to the brain. If we look at the other side, intracranial pressure, what determines that? Well, we can think of the intracranial pressure as a combination of the various compartmental volumes within the brain. The pressure will go up if the volume of stuff goes up within the skull. And what stuff do we have? Well, we have blood within the vessels. So if we get massive cerebral vasodilation, we will also get an increase in intracranial pressure. There's also cerebral spinal fluid. So if that volume increases, we'll get increased intracranial pressure. We know that happens in hydrocephalus. And then there's the tissue edema. So the brain tissue itself can increase in volume, causing an increase in intracranial pressure. And looking at it in this compartmental way is quite useful because it also tells us how we might be able to address a raised intracranial pressure in a particular patient. If it's cerebral edema, we may be able to use something to try and dry out the brain, mannitol or hypertonic saline. If there's too much CSF there, well, we can try and take it out with a ventricular drain or with a shunt system. If there's too much blood within the vessels, we can try some hyperventilation to try and decrease that blood volume and decrease ICP. Obviously, there are potential downfalls or complications of all three of these methods. So in summary, the blood flow to the brain will be related to the arterial blood pressure minus the intracranial pressure. And in neurocritical care, we give that a special name, the cerebral perfusion pressure. This is important because it's something that we can monitor to know if the patient is doing badly in terms of their brain blood flow, but also it's a potential mode of therapy because we can quite easily augment that arterial blood pressure with some noradrenaline or some other vasoconstrictor. Okay. So intracranial pressure, what happens when it goes up? Is it bad? Well, I think you probably know the answer. Yes, it is bad. We expect that it will decrease cerebral blood flow and cause ischemia. Do we see that? Well, here is some data that was from some New Zealand rabbits, 32 New Zealand rabbits, where intracranial pressure was increased from baseline levels up to very high levels, 70 millimeters of mercury through a lumbar CSF infusion. With this dramatic increase in intracranial pressure, we could see that there was a steady decrease in cerebral blood flow. Note here that it's not quite a smooth linear relationship, and I'll come back to that in a few slides' time. So this is an animal model. What about in humans? Well, that, as you can imagine, is a little bit more difficult to study. We don't really want to be infusing fluid into people's spines just to try and understand cerebral blood flow, because that is a potentially dangerous procedure. But we can do something else. We can look at patients who have refractory intracranial pressure. So patients that come in after traumatic brain injury, initially their intracranial pressures are fine, but then over the ensuing hours to days, the intracranial pressure increases as a result of the cerebral edema, and then we can measure a surrogate of brain blood flow. And in the neurotrauma setting, what we often use is the brain tissue oxygenation. So this is a probe that goes into the brain parenchyma through a hole in the skull, and it's the Clark electrode which assesses the oxygen tension within a specific area of the brain. And we can see that when the intracranial pressure increases from here, we have 15 up to almost 80, we see a steady decrease in brain tissue oxygenation, reflecting most likely a steady decrease in brain blood flow. But note, however, when we look at the individual responses, this is just in 1, 2, 3, 4, 5, 6, 7, 8 patients. It's quite a variable response. Some patients are relatively well protected from the increase in intracranial pressures, where some have a dramatic decrease in brain oxygenation. Okay, so in clinical terms, how do we use the information that we have, knowing that intracranial pressure is bad for patients? How do we apply that in the practice? Well, this is the intracranial pressure treatment algorithm, or cerebral perfusion pressure algorithm from my old institution. You can see it's very prescriptive, but we use what we have here, a target of 20 millimeters of mercury. We're always trying to keep the intracranial pressure lower than 20 millimeters of mercury, and we have a stepwise protocol of more and more barbaric things that we might do to decrease that pressure. And at its most barbaric, we have, here we go, lopping some of the skull off, this decompressive craniectomy, to try and give the brain some extra room to swell into. But you may be thinking, surely it's not as simple as just a threshold of 20 millimeters of mercury. Surely it must depend on, for instance, how long is it above 20 millimeters of mercury? Is it worse if it's 30 millimeters of mercury compared to 25 millimeters of mercury? Well, that's all very intuitive. One of my studies, I wanted to try and quantify that. This is the result of my quantification. Quite a busy graph here, so I'll try and go through it quite slowly. This, incidentally, is from a cohort of 750 traumatic brain injured patients at Annenbrooks Hospital in the UK who all had high frequency intracranial pressure monitoring, and they all had their outcome, their clinical outcome, measured 6 months after the injury using the Glasgow outcome scale, where 1 is dead and 5 is a good recovery. And what we can see here, obviously, we see the intensity on the x-axis and the duration on the y-axis. And this is looking at intracranial pressure insults. So for each insult that we identify in a patient time series, we can characterize it as being greater than a threshold of ICP and greater than a threshold of duration. And if we have a blue color here, that means that the more episodes a patient had in this sort of time and intensity category, it was associated with better outcome. Whereas in these red zones here, it means that the more episodes that were in this particular category of intensity and duration was related with worse outcome, as denoted by the correlation between the number of episodes and the Glasgow outcome scale. So all these blue are good, the red are bad, and so we can appreciate that, say, if we had intracranial pressure of around 15 millimeters of mercury for about 50 minutes, well, that's not too bad. That would still be, in this cohort at least, associated with a good outcome. However, if we still had that intracranial pressure of 15, but we had it for 3 hours or so, this would be associated with worse outcome. So this is quite intuitive, but it's actually really important at the bedside, because the things that we do to try and decrease intracranial pressure can have profound negative effects on the patient's health, with the obvious one being, if you take off some of the skull, that has potentially terrible consequences for the circulation of cerebrospinal fluid and also infection. This wasn't really too unexpected. I was quite pleased with the stark contrast between the good outcome and worse outcome, and perhaps that's more apparent if we look at it in 3D, and we can see that there's quite a sharp demarcation between the episodes that were associated with good outcome in blue and bad outcome in red. And so moving on, going back to the problem of how do we try and improve this outcome here of 30%. One of my earlier studies, I wanted to look at how we were doing within our institution over that sort of time period from the 1990s onwards. Surely in a institution that has an active neuromonitoring program, we're not having this static rate of mortality. Hopefully we're improving. So I had a look. We had 1,100 patients over a 25-year period who had high frequency intracranial pressure monitoring data. This was at Addenbrooke's Hospital. And over that time period, naturally, there were some changes in the management. We went from a ward-based system to a neurointensive care system. Targets for the cerebral perfusion pressure were changed. Additional monitors, such as the brain tissue oxidation monitors, were added. And as a result of that, we had some quite profound changes in the physiology within the brain. So looking first at the intracranial pressure, you can see over that same 25-year period, the mean intracranial pressure for the patients went from almost 20 millimeters of mercury down to below 10 millimeters of mercury. So that seems quite promising on the face of things. And we can see also quite profound changes in cerebral perfusion pressure, which incidentally coincides with changes in recommendations from the International Brain Trauma Foundation. But what about outcome? Because that's really all that matters. Well, this is the mortality in 5-year epochs dating back to 1990. It's quite disappointing to see that there is no significant improvement in mortality. We see a trend here maybe, but that's still, I think, quite disappointing. So why are we not improving outcome in a tertiary centre which has an advanced neuromonitoring program, advanced traumatic brain injury research program? Are we missing something with our complex protocol like I showed you just before? Well, I wanted to look in one of my projects at the cerebral perfusion pressure, maybe we can find some useful information in that which may highlight where we've gone wrong and what we might be able to do better in the future. So here we have some signals. It's all very well looking at thousands of patients worth of data, but I thought it would be a good idea to look at individual patients. And time again, I'd find situations like this, where we'd have a signal, in this case, cerebral perfusion pressure, and we'd have it in a patient who had a good recovery. So that means that they are going back to work after their traumatic brain injury with minimal lasting impact of their trauma. You can see over this is over a 3-day period, we have quite a variable cerebral perfusion pressure. It comes up and down and swings. It has, well, we're down to almost 40 at one stage, and then we're coming up to 90 at some stage. And that really reflects the pathophysiology of trauma. Often it doesn't occur to the head alone. Often it's multi-trauma, and we have problems with maintaining blood pressure due to bleeding in other parts of the body. And also we're actively trying to treat that low blood pressure sometimes with vasopressors or even inotropes. So that's a patient with good recovery. What about a patient with fatal outcome? Well, it looks pretty similar to me. We see similar ranges in the cerebral perfusion pressure, and it seems just as wiggly to the naked eye. So are we missing something by just looking at the cerebral perfusion pressure? It's probably a loaded question, and you can imagine I'm probably going to try and tell you that we are missing something. So I'll just go ahead to do that. So if we come back to our physiological model, we've outlined that blood flow will be related to the cerebral perfusion pressure, but it's not exactly a linear relationship. And I've alluded to this before, but this turns out to be quite an important concept after traumatic brain injury. So I will go into that a bit more. So it's not a straight line between perfusion pressure on the x-axis and blood flow on the y-axis. And of course, it won't be new to many of you, but it's a cerebral autoregulation curve, which is more of a sigmoid type shape that has this zone of flat cerebral blood flow, despite having a wide range of perfusion pressures. How does this occur? Well, it occurs through active changes in vascular tone within the brain. So if you imagine here, we have a cerebral perfusion pressure around 100, and we drop it to around 60. How does the brain maintain its blood flow? Well, it actively vasodilates despite the decreased perfusion pressure. However, this only classically works within a certain range, and if the blood pressure or perfusion pressure gets too low, then the vessels will start to collapse and we'll get a steep decrease in blood flow, and the analogous situation happens up here with increasing blood flow. So ideally, you can imagine that we may be wanting to keep this cerebral perfusion pressure somewhere above this elbow here, somewhere before the blood flow starts to decrease precipitously. Well, where did this data come from? Well, it came from Copenhagen, actually, and it comes from this figure here, which you can imagine is quite an imaginative line of best fit that we have here. This is a study, or a review really, which looks at 11 different previously published studies where it's plotted the average blood pressure and the average cerebral blood flow for groups of patients under different physiological conditions and even patients that have various different diseases. And the concept is that if the mean arterial pressure goes too low, then we have a precipitous decrease in cerebral blood flow. This has been criticised quite a bit in recent years as it's not showing within what's happening within a patient, and there are lots of reasons why, potential reasons why these groups of patients may have lower brain blood flow. But I still think this is quite a useful concept for cerebral autoregulation, and you will see that it is shown to be useful in traumatic brain injury. So after trauma, well, we'll go back to the normal situation. This shows a nice flat autoregulatory zone. This is what we might expect in a healthy person, but the situation is quite different after trauma. These are all hypotheticals, but we can imagine maybe the zone of autoregulation, where the blood flow is flat, may be reduced in width in someone who has a brain injury. We can also imagine that this whole curve may change in different aspects of the patient's physiology. If, for instance, they develop hypertension and evolving cerebral edema, maybe a higher cerebral perfusion pressure would be needed. And also, we can easily imagine that a curve for one person may not be the same as a curve for another person. What do we do about this in clinical practice? Well, unfortunately, we don't have accurate and reliable monitors of cerebral blood flow. And either way, it's really too late if we have to draw a whole curve like this with cerebral perfusion pressures down in the 30s and then think, oh, in retrospect, we should have been keeping the cerebral perfusion pressure here. What we really need is some real-time dynamic indicator of how well those brain blood vessels are reacting. And well, my old supervisor, Professor Chosnica, came up with a method back in the late 1990s, which is really quite a simple and maybe even simplistic way to assess brain vascular function, but it's turned out to be quite useful. And I'll go through this quite slowly because I think it's an important concept to understand. So if we think of the case where the vessels within the brain are not healthy and are not reacting well to change in blood pressure, we can imagine what would happen. When we have a drop in blood pressure, the vessels would passively constrict. When we have raised blood pressure, these brain blood vessels, after some delay, would start to passively expand. And the useful thing about the brain and the fact that it's within this rigid skull is that if we have an increase in the vessel caliber, we have an increase in cerebral blood volume, and we'll also have an increase in intracranial pressure. And intracranial pressure is very easy to measure in a critically ill patient. We just need to drill a hole in the skull and put a pressure monitor in there. A lot easier than cerebral blood flow. The interesting thing is if we then plot the arterial blood pressure against the ICP, we find an interesting relationship. And you can imagine that in this case, where the vessels are just acting passively, we find an almost linear positive relationship. And if we draw a line of best fit, calculate the correlation coefficient, we will find a correlation coefficient that will be close to +1. And so we can infer that if the brain vessels aren't reacting well, then we'll have a correlation of close to +1, and we call that the pressure reactivity index of close to +1. And if we go into the opposite scenario, where we have good brain vessel function, we can appreciate if we have a drop in blood pressure, these vessels will actively vasodilate. If we have an increase in brain arterial blood pressure, they will actively vasoconstrict in the attempt to keep this brain blood flow at a constant level. And I'm sure you would have worked this out already, but if we then plot the blood pressure against the intracranial pressure, in this case, we will find a negative relationship. And if we calculate correlation coefficient, it'll be close to -1, and that's what we have, a PRX that is negative, indicates good brain vessel function. Useful thing in traumatic brain injury is that we can measure this continuously. We can calculate the mean blood pressure every 10 seconds, mean ICP every 10 seconds, and then we can calculate the correlation over a window of, say, 5 minutes, and then do the same each minute. And so we get a continuous indicator of how well the brain blood vessels are functioning. Okay, so how do we apply this at the bedside? Well, we can look at this brain vessel function, the PRX, and we can look at it against the cerebral perfusion pressure. The interesting thing that we find is that we have a U-shaped relationship. at a certain cerebral perfusion pressure. On this figure, it's 75. We'll find quite a negative pressure reactivity index. So that is good brain vessel function or efficient PRX, where we have a negative relationship between arterial blood pressure and ICP. But it's U-shaped, so we have areas at both high and low cerebral perfusion pressures, which are associated with poor pressure reactivity index. That is where the map is directly related to the ICP. And we can see here, we have I won't call it arbitrary, we have a specific point that we can denote as impaired pressure reactivity index. And we can get our intercepts. And so this intercept here, we could say, is where we have a lower limit of pressure reactivity index. A lower limit of reactivity, or analogous to that shoulder on the autoregulation curve, the lower limit of autoregulation. The useful thing about this technique is this can be also calculated continuously and updated continuously. So potentially we could have a continuous measure of the lower limit of autoregulation in these patients, and that is a tangible target for the clinicians to work with. So how do we use it at the bedside? Well, if we flip that figure around, imagine we can get these points here. This here would be the CPP, that's the lower limit of autoregulation. You can check again a few minutes later. That may have changed. A few minutes later may have changed again, and a few minutes later may have changed again. So we have a moving target to use. So how did I test this? Well, after coming up with the idea, we looked back at 730 patients who had this high frequency intracranial pressure and arterial blood pressure monitoring, and also had their outcome measured 6 months after the injury. Importantly, the intracranial pressure and the perfusion pressure were not managed according to some computerized algorithm. They were managed according to what the Brain Trauma Foundation said. So in our case, that was an intracranial pressure was to be try to keep it below 20 and a cerebral perfusion pressure above 60. We calculated these U-shaped curves with a second order polynomial. We used mainly 4-hour windows of data to try and construct these curves. We calculated the intercepts where the pressure reactivity index equaled 0.3. This is the threshold that I talked about before. It's not quite an arbitrary threshold, but I won't go into the details of that. We used various jiggery-pokery to try and increase the yield of this lower limit of autoregulation. Unfortunately, data is not always clean and tidy, and in some time windows, maybe we could not construct a nice U-shaped curve. So we advanced our window from 4 hours to 4 hours 10 minutes, 4 hours 20 minutes, 4 hours 30 minutes to try and increase the yield where we didn't get a good shaped curve. Then I used R to calculate the percentage of time for each patient that the CPP was below the lower limit of reactivity. And then I looked at how this related to the mortality of these patients 6 months later, or the rate of unfavourable outcome. Unfavourable outcome includes severe disability and persistent vegetative state along with mortality. Okay, so let's go back to our 2 cerebral perfusion pressures that we looked at before, but let's overlay some physiological context to that. So we have the black line, which is the patient's actual cerebral perfusion pressure. And underneath it, we have this blue zone here, which the blue zone indicates the lower limit of reactivity. This orange zone up the top indicates the upper limit of reactivity. And the yellow zone indicates the zone of working reactivity. And we can see that although this black line is wiggling up and down quite vigorously, it is almost always above the lower limit of autoregulation or reactivity. So the patient is relatively protected from cerebral hypoperfusion. And if we go and look at the next case, and you remember this was the case with fatal outcome, we see a similarly labile cerebral perfusion pressure, but in this case, The cerebral perfusion pressure in black is often in this blue zone, so that means it's below the lower limit of water regulation or pressure reactivity, and therefore the brain is vulnerable to cerebral ischemia and neuronal cell death. So that works very well in these two cherry-picked examples. What about in the whole cohort of patients? Well, probably for bioengineers, this looks like a fairly pathetic rock analysis. But for biologists, it seems quite promising. Here we have in purple, we have the rock curve for the percentage of time each patient had a CPP which was below their individualized lower limit of reactivity, and how that could distinguish between the patients that died and those that survived. We've compared it with a few things, and I want to just focus on this green line here, which is the percentage of time that the CPP was below 60 millimeters of mercury. Chose this comparison because this is currently what the Brain Trauma Foundation recommends in terms of treatment targets. So we can see that the area under the curve for our individualized signal processing enhanced cerebral perfusion pressure target is 0.73, whereas for the bog standard percentage of time below a fixed threshold is 0.64. We also looked at these rock curves at distinguishing between those with favourable and unfavourable outcome. Slightly less impressive, but again, we see the same trend, that percentage of time that the CPP was below the lower limit of reactivity was the strongest determinant of patient outcome. That's our univariate analysis. What about when we look at the multivariate analysis, adjusting for things that we know are associated with poor patient outcomes? So in this case, we adjusted for the mean intracranial pressure, we adjusted for the patient age, and we adjusted for their initial Glasgow Coma Scale. It's a marker of injury severity. And we found that the percentage of time that the CPP was below the lower limit of reactivity remains a significant predictor of patient outcome, with a slightly more favourable area under the curve of this multivariable model. Okay. So this is all in retrospective data, and there are a lot of caveats, I'm sure you all know, to interpreting retrospective data. So we have moved forward with a prospective randomized controlled trial. And this is partly because you can imagine it's a difficult thing to ask a doctor to trust the number a computer is telling them when they normally are relying on their knowledge of physiology and their 30 years experience in dealing with patients or whatever. So we needed to try and show that, first of all, that it was feasible to calculate this at the bedside and the mechanics of how we relay that to treating clinicians. But also we have to know that it's safe to try and target a computer algorithm-derived cerebral perfusion pressure. So that was the basis of this Cogitate trial, which is done in Cambridge, Leuven, Maastricht, and Nijmegen. This is quite a small feasibility study, just 60 patients, and we finished data collection in January of this year, and so hopefully we'll have some preliminary analysis done on that in the next 6 months or so, before then moving on to, hopefully, if it's successful, some sort of outcome study. Okay, so I've talked a lot about traumatic brain injury, but these principles of understanding the landscape of physiology, not just a single number, apply to other illnesses as well. An obvious one is after hypoxic ischemic brain injury. So after a cardiac arrest, what sort of blood pressure should we be aiming for? We can use almost exactly the same methods in those patients. And this is a study by one of our colleagues who has shown some initial promising results in a small group of only admittedly 10 patients. Perhaps the most exciting application of individualized pressure targets comes from this group from Chicago, who have done a randomized controlled trial of about 400 patients, looking at using whatever the standard targets for arterial blood pressure during cardiopulmonary bypasses, with using an auto-regulation guided individualized blood pressure target. using a similar but not the same method as I've just outlined before. They haven't published their main primary outcome, but they have published some interim analysis looking at the effect of targeting an individualized blood pressure on rates of post-surgical delirium in these patients. And they found that in the group that was randomized to have the individualized target, they had significantly less post-op delirium. So encouraging findings there. So what about local projects? I'm just really getting started back here in New Zealand with my research, and I've been lucky enough to be introduced and touch base with two other researchers who were already doing very similar research. And this is first Anusha Gunashallingam, who's one of the pediatric intensivists at Starship Hospital. And she's just started a study using near-infrared spectroscopy to determine cerebral autoregulation during cardiopulmonary bypass in neonates and in the 24 hours after their operation, and trying to see how that relates to magnetic resonance imaging of the brain and indicators of brain injury. And also started doing some work with one of the perfusionists, Gaz Jaibur, and his supervisor, Simon Mitchell, looking at transcranial Doppler-derived cerebral autoregulation indices and how that relates to air embolism during cardiopulmonary bypass. That is, when they open the heart, some air gets sucked into the circulation. What sort of effect does that have on the brain vascular function? So these projects are just really getting started, but I'll be interested to see what they reveal. So in conclusion, intracranial pressure and cerebral autoregulation are important pathophysiological variables after brain injury, but they're only important if you're measuring them and you're analysing them. And secondly, continuous individualised physiological targets after brain trauma are possible and have prognostic value. I don't want to get ahead of myself here, because at the moment we're only dealing with retrospective data. We really need to wait until we can prove it's safe to do in a prospective setting, and then prove that it's hopefully has some benefits for the patients. But finally, and I think this is the part where engineering friends can come to save the day, that collection and analysis of bedside signals is imperative. It shouldn't just be if there's a researcher whose particular interest is in cerebrovascular physiology. We should be collecting this data, analysing this data in an attempt to improve patient care, because if we're not, we're stuck with that 30% mortality for these very sick patients. I think that's all I've got for today. I'd just like to thank Professor Simon Mitchell, Head of Department, and of course my PhD supervisors for when I was back in Cambridge. It's Marek Chosnica and Peter Smilewski. I'm happy to take any questions that we have.
Right, so this is now open for questions. So you can either send your question through the chat box, or you can unmute yourself and ask a question as well.
So I can start, Joe. Very interesting data, and you know, we're looking retrospectively, as you pointed out numerous times, and one of the challenges is just in general collecting such data in a normal clinical environment. You're doing it in almost a research environment, but the ability to intervene, as you say, to say, well, we think this parameter, I don't know, for the one that I know well, sympathetic activity is going up, I tweak that. But in essence, one of the things that has always struck me is we lack a number of good animal models to go forward to test the hypotheses that you might develop. And I sort of, you know, I think one of the issues is you're showing a very long period of time that Marek has collected the data over the 700 patients. That's fantastic. But then how do we go forward to make predictions about what we might change, what we might alter to look for improvement? So I guess what I'm wondering, maybe there's a question in here, is don't we actually need really good validated animal models, or an animal model that everyone would use in the TBI area, that would enable us to test hypotheses for improving treatment, because we can't wait another 25 years until you've changed X and found an improvement. I mean, what do we do?
Yeah, I think you're absolutely correct there, Simon. I think probably the easiest thing is to analyze screeds of data that people have collected, but that's not the ideal situation. The ideal situation is that we have animal models and we know what happens when, for instance, we change the cerebral perfusion pressure to that animal's individualized optimal perfusion pressure. Unfortunately, there seems to be very little interest and or expertise in these animal models for traumatic brain injury. We know in Johns Hopkins, there's Ken Brady's original group that did quite a few studies in a piglet model, and that data, perhaps similar to the clinical data from Cambridge, has been used and reused probably too many times. We need to be doing this research concurrently with the clinical collection of data. So I'd really be ecstatic if there were basic science and physiology researchers who were interested in looking into traumatic brain injury models.
So Vicky, I've got a question here. So there was a very interesting talk. One of the things that struck me though was the somewhat arbitrary selection of, was it a 0.3 slope of the autoregulation curve? How important is that? I would imagine that as you deviate, to higher values, of course, it's going to lead to much worse outcomes. But there seems to be a grey area, where you can approach the value that you chose. But I guess I'm asking, how did you choose that value, and how important is it to stay within the or below the 0.3?
Yeah, so great question. You're right, with this pressure reactivity index, we know if it's definitely good. If it's a number close to 0, it means there's no relationship really between the variables, or even if it's negative, that's good. If it's above 0.5, it's very bad. But where do you draw the line in the middle? We weren't exactly sure on the best place for this, and it does have important implications, because you can imagine if you put it closer to the 0 end, you would get a narrower range of intact autoregulation, whereas if you said, oh, we can accept pressure reactivity index up to 0.4, then we would have quite a wide range, and that has an effect. If you're using this for clinical input, then you could be pumping full of vasopressors in one situation and not in the other. The reason that we went with 0.3, there are two reasons really. Firstly, we looked at a cohort of patients, it's about 300 patients, and what the optimal cut point was that distinguished between those with bad outcome and good outcome, and that turned out to be 0.28, I think. And the other reason that we chose 0.3 is that in this animal model, which I alluded to earlier, piglet model of traumatic brain injury from the Johns Hopkins group, they gave the piglets a traumatic brain injury and then gradually decreased their cerebral perfusion pressure using a vena cava balloon. And at PRX of 0.3 was where they saw the invasively measured laser Doppler flow, the blood flow of the brain, started to decrease precipitously. But that was in a piglet model, which we don't necessarily know would be the same as in the brain, but that's the general reasons why we chose that threshold.
Is it related to the time at which you're outside of that that region as well?
Sorry, could you repeat that?
Is it also related to the length of time that you're outside of that safe region?
Yeah, no, you're right. I mean, I think it would be similar to like the that complicated three-dimensional figure that I showed, that it's not just the threshold, it's also how long you're outside it. And it's particularly important for this pressure reactivity index, because it's just a simple correlation, and therefore it's very, very noisy. And so in essence, what we see is that you could have a PRX of 0.8 for 5 minutes, and then the next 5 minutes, maybe it could be 0 or something like that. And so we need to have a period of time for it to stabilize. And what the optimal period of time to make that assessment is, we are also not sure. We use 5-minute averages as some sort of compromise, but it is a compromise.
Right. Thank you.
There is one question in it.
Yes, yeah. So from Vishal, just out of the context, is there any relation between oxygen therapy and cerebral blood flow? Yes, there is. We know from basic physiology studies that when we have low oxygen levels in the blood, that the brain vasodilates. So the brain blood flow is increased with low oxygen, and the analogous situation occurs if we give hyperoxia, then brain vessels constrict. This is quite important in all critical care patients, but particularly in traumatic brain injured patients. Although it might be intuitive that an increase in brain blood flow is a good thing, if we're achieving that increase in brain blood flow by hypoxia, delivery of oxygen to the brain will likely be decreased. And also we have that confounding influence of, if we get vasodilation in a brain that's already swollen and has low compliance, then the intracranial pressure will start to shoot up, which therefore will decrease the perfusion pressure, and then we can get into a vicious cycle that can result in, paradoxically, a decrease in brain blood flow. So a simple question, but not such a simple answer.
I have one question. So do you use any other biomarkers, like maybe is MRI part of the standard clinical care? Then if you have like other MRI modalities like body flow, and then can you sort of relate that with your cerebral perfusion pressure measurement somehow? Would that sort of increase your diagnostic ability? Yeah,
I think it would be very useful. It comes back a little bit to Simon's question about how a lot of the work that's out there is just observational studies of how signals relates to outcome, but we don't really know the in-between. What's the effect on, say, brain structure? And that would be the intermediate between the signals that happen in the acute phase and the outcome that happens 6 months later. I know within the Cambridge imaging group, they have actually done some acute MRI scans in the intubated patients, looking at tractography and which tracks have been affected by the brain injury. But unfortunately, we haven't yet married it up with our signal processing data, and I think that would be very interesting to see how, say, fibre tract loss relates to the autoregulation or pressure reactivity index within the brain during that acute phase.
Yep, there's another question.
Yep, from Sam P. Thanks, Joe. Could you please update any roles of other interventions to reduce ICP in severe traumatic brain injury? For example, hypothermia, CSF microdialysis, or deep sedation. Yeah, well, if we look at an evidence-based approach, we would say that the only intervention, ICP lowering intervention, that has an effect on outcome is chopping part of the skull off, the decompressive craniectomy that was shown in the Rescue ICP trial a couple of years ago to decrease the mortality after severe traumatic brain injury with raised intracranial pressure, but at the expense really of ending up with more patients in the severely disabled category. So that's the only evidence-based treatment, and even that has quite significant ethical considerations. In terms of hypothermia, the Eurotherm trial showed that it was definitely effective in decreasing intracranial pressure, but it was not effective at all in outcome. The outcome was the same in the hypothermia group as it was in the normothermia group. However, there are also caveats to that sort of study because it depends when you start to give the hypothermia. If you use it as an early ICP lowering therapy, say with only modest increases in intracranial pressure, then you are more likely perhaps to expose a patient to the negative effects of hypothermia related to mainly cardiac and pulmonary complications. So there is an argument that perhaps we need to also do a study of rescue hypothermia when it's used as a high-tier ICP lowering therapy, like it was in the Adam Brooks Hospital protocol. In terms of microdialysis, this is a very interesting technique that uses a small microdialysis probe to measure small molecules within the brain and particularly related to metabolism, so we can get an index of anaerobic metabolism, the amount of lactate to pyruvate ratio, which is generally the only validated parameter, and it's validated in the sense that those with an elevated lactate pyruvate ratio have worse outcome. Again, it's only used in a few centres, and it hasn't been shown that if you use all these sophisticated monitoring techniques that you improve outcome, but it's really something I think we have to watch for in the future because it has the potential to inform physiological models, which hopefully down the track can improve patient care. And finally, deep sedation, another one that's not been very well studied because these patients are very, very sick. To put someone on the phenobarbital thiopentol, they already failed all their previous therapy. So my understanding is that it works quite well in decreasing the intracranial pressure, but most of these patients, or a lot of these patients, end up with very bad outcomes. And another one, CBF is well regulated in the healthy brain, but as you suggest, maybe not in the injured brain. Do you reckon there is a similar relationship for ICP, or is ICP a passive outcome of other regulated variables? Yeah, well, that's a difficult question because of the nature of intracranial pressure. We don't know what it is in healthy humans. I would tend to go for this latter, is that ICP is a passive outcome of other regulated variables. Having said that, we can approach this question using non-invasive markers of intracranial pressure, which a lot of you know a lot about. So we can look at the optic nerve sheath diameter, or we can look at various indices from the transcranial Doppler. But I think that's a good question, and I think we probably won't know the answers until we start sticking needles in healthy people's backs. And I don't know if I want to volunteer for that study.
Okay, if there is no more question, then we can conclude today's seminar. Thank you, Joe, again for coming to the Zoom seminar and give us fantastic talk today. Really, really appreciate that.
Cool. Thank you very much, everybody.
Thank you.